it fine? Yes. Okay. Good afternoon, everyone. I'm Rajeeta Basur from Mata Gujri Medical College and LSK Hospital. I'm here to present the case of Mr. X, 53-year-old male from West Bengal. He came to the OPD with sudden drooping and lateral deviation of left eye since 15 days. This was accompanied with weakness in the right side of the body. It was not associated with any pain, swelling, or redness, no history of trauma or drug intake, no significant past or family history. The patient was not a known case of any systemic diseases. The patient was a moderately built, well-nourished man. He was calm, conscious, and well-oriented to time, place, and person. He had right-sided upper and lower limb weakness. Muscle strength was 3 out of 5 on the right side. There was no associated dysphagia, aphasia, dysarthria, or any cranial nerve palsies. The rest of the neurological examination was normal. His blood pressure was 110/70. His complete blood count, blood sugar, renal and liver function tests, thyroid function tests, procoagulant workup, echocardiography was all normal. He tested positive for hepatitis C. His best corrected visual acuity in the right eye was 6.9 and in the left eye was 6.12. Slit lamp examination of anterior segment in both eyes was unremarkable. Intraocular pressure was 14. Gonioscopic examination was normal. Left eye examination, there was severe ptosis. Here we can see there was severe ptosis with restriction of medial rectus, inferior oblique, and superior oblique with non-reactive pupil. In primary gaze, the left eye was oriented down and out. Restriction of ocular movements of the left eye in superior, medial, and inferior gazes. The posterior segment of right eye as well as the left eye was well within normal range. In the MRI, we saw that there was a focal ill-defined lesion involving hemi-midbrain anterior to the red nucleus extending into the oculomotor fascicle as it exits the midbrain ventrally into the root exit zone, causing its diffuse thickening up to the oculomotor dural cave. In MR angio, we saw that there was high-grade neurovascular conflict between oculomotor nerve and superior cerebellar artery. Partial vascular loop is formed between left posterior cerebral and left superior cerebellar artery. Left posterior cerebellar artery is hyperplastic. We can see this left posterior cerebral artery is hyperplastic with a branch near posterior communicating artery, completing the vascular loop with superior cerebellar artery, at which there is compression of oculomotor nerve as it exits the midbrain. Based on clinical and radiological findings, a diagnosis of Weber syndrome was made. Weber syndrome is a rare brainstem stroke due to midbrain infarction and is characterized by crossing hemiplegia, consisting of ipsilateral oculomotor nerve palsy and contralateral limb weakness. The most common etiology is midbrain infarction caused by occlusion of the posterior cerebral artery. Although there are many multiple brainstem strokes, this is uncommon to see this syndrome. Our patient was referred to a neurologist where the patient was started on antiplatelets and paracetam. There can be different differential diagnoses like Benedict and Claude syndrome. Benedict syndrome is also called paramedian midbrain syndrome. It is caused by insult to the tegmentum of midbrain and cerebellum. It is characterized by presence of oculomotor nerve palsy and cerebellar ataxia, including tremor and involuntary chorioathetotic movements. Claude syndrome is similar to midbrain syndrome. Like in our patient, we had ipsilateral oculomotor nerve palsy and contralateral hemiparesis, but it also includes contralateral ataxia. Thank you.